picture this. There is a chronic, progressive physical condition that will eventually affect up to 84% of women as they age.
Right. It's a massive number.
Yeah, and it alters your daily comfort. It dramatically impacts physical intimacy, and it fundamentally changes the cellular structure of your body.
And yet, despite being experienced by, the vast majority of half the population, 70% of doctors never even bother to ask their patients about it.
It's just wild to me.
It really is a staggering oversight in modern medicine. I mean, we are talking about a cascade of physiological changes that are entirely treatable.
But because of this historical lack of communication, and honestly, a mountain of misconceptions, millions of women are left to just grit their teeth and endure it.
Exactly. They just suffer in silence.
So today we are diving deep into a topic that so many of you listening might be experiencing right now, but you perhaps thought you were entirely alone in dealing with it.
Which you absolutely are not.
Right. We are pulling from an extensive stack of clinical guidelines today. We've got the British Society for Sexual Medicine, NAC, and the American Urological Association.
Plus some incredibly promising data on minimally invasive gynecological technologies.
Yeah, those device trials are fascinating. But the goal today isn't just to, list off medical terminology. We need to untangle a very specific, highly debated question in women's pelvic health.
Right, the order of operations, basically.
Exactly. If a woman feels a structural change, like a looseness, or what the clinical literature calls vaginal laxity, does she actually need to treat a hidden underlying cellular condition before anyone even considers a surgical fix?
And to answer that, we have to completely rethink how we view the tissue we're actually talking about.
We really do, and I think we have to start by addressing that massive communication gap you just mentioned.
Oh, the terminology issue, yeah.
Right, because for a long time, the medical world used terms like vulvovaginal atrophy or atrophic vaginitis.
Which are just terrible terms.
They really are. I have to be honest, before digging into this material, those terms sounded to me like an inevitable, purely cosmetic symptom of just getting older. Like wrinkles, but elsewhere.
What's fascinating here is that the medical community finally realized those old terms were doing a massive disservice to patients.
Thank goodness.
Right. So in 2014, medical societies officially introduced a new term, genitourinary syndrome of menopause, or GSM for short.
GSM.
Yeah, and they made this shift because the word atrophy felt really stigmatizing. And more importantly, it completely failed to capture the vast spectrum of what women were actually going through.
It made it sound like a localized, superficial issue, like just a bit of dryness.
Exactly. It minimized it.
Right, because it's not just about vaginal dryness or, a loss of lubrication. The old terms completely ignored the severe lower urinary tract symptoms that come with this.
The urinary symptoms are huge.
Yeah. We were talking about recurrent urinary tract infections, UTIs, which can become incredibly dangerous as we age.
Very dangerous, yeah.
And we're talking about urinary frequency, urgency, and dysuria, which is painful urination.
And crucially, the old terminology didn't point to the biological cause at all. The term GSM was intentionally designed to signal that this entire constellation of symptoms, the pelvic pain, the urinary issues, the extreme tissue fragility, is all connected.
It's all one big systemic issue.
Right. It's directly related to a postmenopausal hypoestrogenic state.
Meaning low estrogen.
Exactly. When the ovaries stop producing high levels of estrogen, and this is key when androgens like testosterone also plummet, the entire genitourinary tract goes into a state of severe deprivation.
I think a lot of people forget that women naturally produce and absolutely require testosterone for tissue health, not just estrogen.
Oh, absolutely. It's critical for tissue integrity.
And the numbers on this deprivation are just mind-blowing. The British Society for Sexual Medicine notes that up to 70 to 84% of postmenopausal women experience GSM.
We are talking about nearly everyone.
Almost everyone. But here's the statistic that literally made me stop in my tracks. Out of all those women, only about 7% actually receive treatment.
It's tragic, honestly. And that disparity between prevalence and treatment is almost entirely driven by the misconception that this is just, your lot in life as an aging woman.
You just have to put up with it.
Right. A patient experiences severe dryness or dyspareunia, which is the clinical term for painful intercourse, and she assumes it's just an unavoidable penalty of menopause.
So she doesn't bring it up to her doctor.
She doesn't bring it up at all.
And if you're listening to this and thinking, well, my doctor never brought it up to me either, you were definitely not alone in that.
Not at all.
The clinical guidelines explicitly highlight that 70% of healthcare professionals admit they rarely or never initiate conversations about vaginal health with menopausal patients.
They just avoid it.
Yeah, so the patient assumes it's a lost cause. The doctor avoids the topic because maybe they're uncomfortable or rushed, and the cycle of silent suffering just continues.
We also have to draw a hard line here between GSM and the other menopausal symptoms people usually talk about.
Oh, like hot flashes.
Yeah, vasomotor symptoms, hot flashes, night sweats. Those are undeniably disruptive, but for the majority of women, they are transient.
They eventually go away.
Right. They taper off as the brain and body adjust to the new, lower hormonal baseline. GSM is entirely different. It is a chronic, progressive condition. It does not get better on its own.
Okay, let's unpack this. So hot flashes are essentially a passing thunderstorm. It's chaotic, you get wet, but the weather eventually clears up.
That's a great way to look at it.
But GSM, on the other hand, is like a drought that just keeps drying out the soil. It doesn't magically fix itself. If you ignore a drought, the soil just cracks, becomes brittle, and eventually can't support life.
That visual captures the cellular reality perfectly. The estrogen receptors located throughout the vagina, the urethra, the base of the bladder, and even the pelvic floor musculature, they are quite literally starving.
Wow.
Starving. Yes. Without a continuous supply of that hormonal nourishment, the epithelial tissue physically thins out. It loses its elasticity completely.
It just becomes rigid.
Rigid and fragile. The blood flow decreases, and the area becomes highly vulnerable to micro tears and bacterial infections.
Which brings us right to the core question driving today's deep dives. If the tissue is essentially starving and paper thin due to this GSM drought, what happens when a woman goes to her doctor and says, things feel structurally different down there. I feel loose.
Right, the laxity complaint.
Let's define what that feeling actually is first.
Clinically, that feeling is termed vaginal laxity, or sometimes you'll see vaginal relaxation syndrome in the literature.
Okay.
At its core, laxity is a structural issue. It's a measurable decrease in vaginal contractile strength.
So it's muscular and structural.
Yes. And it most frequently originates from the intense physical stretching and often micro-tearing of connective tissues and the levator-ani muscle complex during vaginal childbirth.
It's the mechanical trauma of delivering a baby. I mean, the muscles and fascia just get overstretched.
They do, but it doesn't stop there. That initial structural trauma is later compounded by the natural loss of collagen as we age.
Right, like skin losing elasticity.
Exactly. And then that loss is dramatically accelerated by the hormonal crash of menopause we were just discussing.
Because estrogen is doing what exactly for that structure?
Estrogen is what actually maintains the robust collagen and elastin matrix that gives the vaginal wall its tone. When estrogen disappears, that internal support structure effectively collapses.
Wow.
So a patient might experience a loose sensation, a frustrating lack of friction during intimacy, or even a persistent feeling of heaviness in the pelvis.
And this is where the traditional medical approach often takes a very risky turn, doesn't it? The literature shows that many clinics, when a patient presents with this complaint of laxity, they immediately offer surgical intervention.
They jump straight to the scalpel.
Yeah, procedures like a vaginoplasty or a labiaplasty, mechanically cutting and suturing to reduce the physical diameter of the vaginal opening.
This raises an important question, though, and the guidelines from the major urological and sexual medicine societies raise massive red flags about that immediate leap to surgery.
Because it's so invasive.
Surgery is inherently invasive, yes. You are exposing the patient to the risks of heavy scarring, nerve damage, chronic pelvic pain, and potential injury to the urethra.
Which are huge risks.
But beyond the standard surgical risks, the bigger issue is the underlying condition of the tissue itself.
Okay, let's unpack this because I want to push back on this traditional surgical approach for a second.
Yeah.
This seems completely illogical based on what we just learned.
It really is.
If a woman asks for surgical tightening because she feels a lack of tone, but her actual tissue is severely atrophic, friable, and paper-thin from untreated GSM surgery, sounds like an absolute disaster.
It's a recipe for complications.
Right. You wouldn't try to stitch together wet tissue paper and expect it to hold tension under stress. Shouldn't the medical priority be feeding and thickening the tissue before you ever pick up a scalpel?
You've hit on the exact paradigm shift these guidelines are trying to push. Skipping straight to surgery is a fundamental misstep in diagnosis and prioritization.
So they have to treat the drought first.
Exactly. The consensus is overwhelmingly clear. You must restore the tissue's baseline physiology first. Treating the GSM is a non-negotiable prerequisite before even considering structural surgery for laxity.
Because laxity and GSM aren't happening in isolation.
Yeah.
I mean, they overlap almost constantly in menopausal women.
They are deeply intertwined. When GSM goes untreated, the vaginal epithelium becomes incredibly pale and friable, meaning it tears and bleeds with minimal contact.
Oh, wow.
Yeah. It also loses its natural rugae.
Rugae. What's that?
Rugae are those corrugated folds in the vaginal wall that allow it to expand and contract dynamically. If a surgeon attempts to cut and tighten that severely estrogen-deprived inelastic tissue, the healing process is severely compromised.
The tissue just can't heal properly.
No, it can't. The chance of painful scarring skyrockets.
Yeah.
And ultimately, you haven't fixed the root cause of the patient's discomfort anyway.
So how do we fix the root cause? How do we stop the drought and actually feed the tissue? The guidelines from NICE and the American Urological Association point directly to localized hormones as the gold standard first-line defense, right?
Yes, we are talking about low-dose vaginal estrogen.
And it is crucial to emphasize the word localized here.
Very crucial.
We are referring to estrogen delivered directly to the vaginal tissue via creams, small insertable tablets called pessaries, or flexible rings.
Right, because many women assume that if they are on systemic hormone replacement therapy, HRT, like an estrogen patch or an oral pill to control their hot flashes, they assume their vaginal tissue is automatically protected.
But the data shows that systemic HRT often doesn't reach the pelvic floor in high enough concentrations to reverse GSM.
It just doesn't get there.
Right. The guidelines actually note that anywhere from 10 to 25% of women currently on systemic HRT still require an additional localized vaginal estrogen treatment.
The localized application bypasses the liver and goes straight to the starving receptors. It's much more efficient. And beyond estrogen, the clinical trials are heavily focused on DHEA right now.
Oh yeah, specifically a formulation called prasterone.
Exactly.
DHEA is fascinating because of how the body utilizes it. It's an inactive precursor hormone.
Right, it doesn't do anything on its own.
Exactly.
Yeah.
When you insert a localized DHEA ovule, the body's own cells take that precursor and convert it directly into both estrogen and testosterone right there inside the vaginal tissue.
And it does that without significantly spiking hormone levels in your bloodstream, which is great for safety.
The restorative effects of these localized treatments are profound. They aren't just masking symptoms, are they?
No, they're literally reversing the cellular atrophy. The epithelium thickens back up to premenopausal levels. The tissue regains its elasticity.
Which is incredible.
And vitally, it restores the normal vaginal pH to below 4.5.
Right, creating an acidic environment that aggressively fights off those dangerous UTIs.
Exactly. It revascularizes the whole area, too. New blood vessels form, bringing back natural lubrication.
And what's really interesting is that the guidelines emphasize combining this hormonal restoration with pelvic floor muscle training, PFMT.
Yes, physical therapy is a huge component.
When a woman works with a specialized physical therapist to actively strengthen the underlying levator anti-muscle bed while simultaneously thickening the tissue with hormones, symptoms that were purely blamed on laxity often just vanish.
It's true. Once you rehabilitate the muscle and hydrate the mucosa, that subjective feeling of looseness is often resolved without a single incision.
No surgery required.
Right. It proves exactly why treating GSM is the mandatory first step. But this brings up a practical challenge.
The timeline.
Yes, the timeline. Hormonal restoration takes time. It can take months of consistent application for the tissue to rebuild itself.
And what if a woman is dealing with both severe structural laxity from a difficult childbirth and advanced GSM, and she's looking for a more immediate intervention, like she doesn't want to wait 6 months to feel better?
Which is a completely valid concern.
Here's where it gets really interesting. This is where the deep dive takes a massive technological twist. We're entering the new frontier of non-surgical energy-based devices, commonly referred to as EBDs.
EBDs, yeah. This isn't surgery, and it isn't a daily cream.
No, it's totally different.
This is arguably the most rapidly evolving area of gynecological medicine right now. The clinical trials we are reviewing focus on treatments utilizing fractional CO2 lasers, erbium YAG lasers, and a technology called dynamic quadrupolar radiofrequency, or DQRF.
Instead of mechanically cutting a stretched piece of fabric to make it tighter, these lasers and radio waves are essentially commanding the body to weave brand new, thicker, healthier threads from the inside out.
That's a great analogy.
They are tackling the GSM drought and the structural laxity simultaneously. But I mean, for anyone who hears the word laser and immediately pictures some kind of sci-fi weapon,
Sure.
how exactly are these devices working without just burning the tissue?
It all revolves around precisely targeted, controlled thermal energy. Let's use the radio frequency devices as an example.
Okay, the DQRF ones.
Right. A small wand emits a highly specific electric field into the vaginal mucosa. This field causes the water molecules inside the tissue to oscillate and collide rapidly.
Basically creating friction.
Exactly. That friction generates heat within the deeper layers of the tissue, usually tightly controlled between 40 to 47 degrees Celsius.
So it feels very warm to the patient, but it stays just below the threshold of actually burning or ablating the tissue?
Exactly the right balance. And this specific photothermal effect triggers a massive biological cascade.
The body thinks it's under attack, right?
Kind of, yeah. The body interprets this controlled heat as a microinjury. In response, it triggers neocollagenesis. Fibroblasts rush to the area and begin synthesizing brand new, tightly wound collagen and elastin fibers.
Building that support structure back up.
Right. It also induces angiogenesis, which is the sprouting of new microscopic blood vessels. So by gently heating the submucosal layers, you are biologically forcing the tissue to restore its own thickness, elasticity, and tone.
When I was digging through these clinical trials, the medical crossover here totally blew my mind. Originally, these energy-based devices were marketed and explored mostly for premenopausal women who wanted cosmetic tightening after having kids.
That was the initial market, yes.
But when researchers started doing cellular biopsies on postmenopausal women who had these laser and RF treatments, they discovered something revolutionary.
If we connect this to the bigger picture of our deep dive, the biopsies prove that these devices weren't just physically shrinking the vaginal canal.
They were doing so much more.
They were reversing the genitourinary syndrome of menopause at a microscopic level. The thermal energy was actually waking up the dormant cells. The biopsies revealed a massive increase in glycogen storage within the epithelial cells.
And for anyone listening who might be rusty on their microbiology, glycogen is basically the cellular food source for lactobacilli.
The good bacteria.
You're right. The beneficial bacteria that keep the vaginal microbiome healthy and appropriately acidic. If the tissue is atrophic and there's no glycogen, the good bacteria just starve.
And that metabolic chain reaction is the precise reason why untreated GSM leads to so many infections.
Because the defense system is down.
Exactly. Without lactobacilli, the pH level rises, and hostile pathogenic bacteria colonize the area, leading to chronic UTIs. The data shows that lasers and radiofrequency treatments rapidly restored that glycogen, eliminated the thin, unhealthy parabasal cells, and allowed the protective lactobacilli flora to flourish once again.
It is literal cellular regeneration. And the patient outcomes in these studies are incredible. Women who hadn't been able to engage in comfortable physical intimacy for years were reporting a return to normal sexual function.
They also saw significant reductions in stress, urinary incontinence.
Oh, wow, right.
And the protocols are remarkably fast, usually just 3 sessions, spaced about a month apart, performed right in a doctor's office with virtually zero downtime.
That sounds almost too good to be true, which means we need to talk about the SDA. We have to impartially report on the current regulatory landscape surrounding this technology, because it is a complex situation.
Very complex. While the peer-reviewed clinical trials published in these major urological journals demonstrate immense promise, very high patient satisfaction rates, and a strong safety profile for treating both laxity and GSM, the FDA has taken a very cautious stance.
Right. The FDA issued specific warnings regarding the marketing of these devices, didn't they?
They did. The FDA has publicly stated that these energy-based devices are not yet officially cleared or approved, specifically for the indication of vaginal rejuvenation or the treatment of menopausal sexual function symptoms.
So doctors are using them off-label.
Yes. The agency noted that they have received reports of adverse events, including burns, scarring, and chronic pain, particularly when the devices are operated by inadequately trained personnel or used outside of evidence-based parameters.
Which makes sense. You need someone who knows what they're doing.
Absolutely. So while the scientific community is highly encouraged by the biopsy data, the regulatory bodies are demanding more large-scale, long-term, randomized controlled trials before they grant broad marketing approval.
It's a classic case of medical technology outpacing the regulatory framework. I mean, the science of neocollagenesis is thoroughly documented, but the guardrails are still being built.
That's a fair assessment.
And the innovation isn't just stopping at lasers and radio waves. The research also highlights injectables, specifically hyaluronic acid HA and platelet-rich plasma, or PRP.
Hyaluronic acid is incredibly well known in facial dermatology, right? For its ability to bind to water, retain moisture, and create structural volume.
Like in lip fillers and stuff.
Exactly. Now, gynecologists are utilizing specific formulations of HA to treat age-related fat lysis. This is the natural, progressive loss of the protective fat padding in the labia majora.
So they use it to plump the area back up.
Injecting HA restores that lost volume, which is vital for physical protection, comfort, and shock absorption during daily activities.
And then there's PRP, which is a regenerative technique where they draw a small amount of your own blood, spin it down in a centrifuge to isolate and concentrate your platelets, and then inject that golden serum back into the vaginal tissue.
The underlying principle of PRP is leveraging your body's own healing architecture.
Using your own biology.
Right. Those concentrated platelets release a massive localized cascade of growth factors. These proteins modulate cell proliferation, they strongly promote new blood vessel formation, and essentially kickstart your body's innate regenerative mechanisms to repair the vaginal mucosa and heighten sensitivity.
So what does this all mean for the person listening right now? Let's bring this vast amount of medical data together. We started by asking a very specific question. Should a woman treat GSM before trying to tighten vaginal laxity?
And we've established that these are highly common, deeply disruptive conditions that almost always overlap.
And the overarching consensus from the global medical guidelines is definitive. You must address the health, thickness, and vitality of the tissue first.
Without a doubt. Performing a structural surgical tightening procedure on severely atrophic, estrogen-deprived tissue is fundamentally flawed and potentially harmful.
Whether a patient opts for localized, low-dose vaginal estrogen and DHEA to slowly rebuild the hormonal environment, or works intensively with a pelvic floor physical therapist.
Or decides to explore these promising new thermal therapies that trigger rapid collagen production.
Right. Whatever the path, the biological goal remains exactly the same. You have to feed the starving tissue, you have to thicken the mucosa, you have to restore the blood flow.
Only after that baseline physiological health is restored can a physician accurately assess if a surgical intervention for laxity is actually warranted.
Because the laxity might just disappear.
In the vast majority of cases, once the tissue is rehabilitated and the pelvic floor muscles are toned, that initial sensation of laxity is resolved entirely.
To you listening right now, the most vital takeaway from this entire mountain of research isn't just about the mechanics of a laser or the dosage of a hormone cream. It is the validation of your experience.
That's the most important part.
These symptoms, the chronic dryness, the pain, the urinary urgency, the frustrating feeling of looseness, they're not just some mandatory penalty of getting older that you have to quietly endure.
They really aren't.
The medical science is advancing at an incredible pace. There are safe, highly effective, minimally invasive options available to restore your quality of life. You just have to know they exist, advocate fiercely for yourself, and ask your doctor the right questions.
Which leaves us with a final lingering thought to consider today.
Yeah.
If the clinical data we review today is accurate, if 70 to 84% of women experience these highly treatable, deeply life-altering physical symptoms, yet a mere 7% actually receive the care they need, what does that staggering silent gap tell us?
It's a tough question.
What does it reveal about how modern society and the medical establishment historically view, prioritize, and validate female pain and sexual health as women age?
We'll leave you to mull that over. It's time we stopped ignoring the problem and started demanding better answers. Take care.